Hi students, welcome to the next video in oral pathology sessions. Okay, we are going to discuss about lichen planus here. So we are discussing about skin lesions in the skin lesions and mucosal lesions, okay, and vesiculobullous lesions. In this video we will discuss about lichen planus. Lichen Lichen planus is our subject today. Actually, lichen planus is a dermatological disease. Okay, it is a disease which affect your skin. So we should use the term oral lichen planus here. Okay, oral lichen planus. Lichen planus is something which comes on the skin actually, and if it comes, the type of lichen planus that comes in the oral cavity is the oral lichen planus. Okay, now it is a dermatological disease that can come, and it is an autoimmune disorder also. This is actually a autoimmune disorder. Autoimmune disorder. But this autoimmune disorder is usually maintained by antigen antibodies. But here, the speciality of this lichen planus is that this is an autoimmune disorder mediated by your lymphocytes. Lymphocytes, or we say cell mediated. This is a cell mediated autoimmune disorder. So you have seen in pemphigus, pemphigoid, etc., the antigen was targeted by the antibody. So pemphigoid, there is an autoimmune disorder where the antigen is targeted by the antibody. But the problem here in lichen planus is it's not the antibody which is going and killing or going and attacking this antigen. It is our lymphocytes going directly and then attacking. So it is a cell-mediated autoimmune disorder. Okay, that's why we call it as a cell-mediated. So you understood the speciality of lichen planus here. Now, what is happening here is that now our body was okay, perfectly okay, and in a day, the Langerhans cells are your antigen presenting cells, APCs. Antigen presenting cells, they are defense cells which is present in the epithelium. Now, they are like policemen actually. They are just policemen. They just look over the epithelium whether something is going abnormal or not. Now, one day this Langerhans cell got to see the basal keratinocytes. Okay, on the basal keratinocytes, they found some antigen called LP antigen. LP antigen, they don't know LP antigen. This LP antigen, they found that this is some kind of foreign antigen. Okay, so LP antigen was misdiagnosed or misread as foreign antigen by this Langerhans cell. Okay, so Langerhans cell was doing the surveillance. By chance encounter, what happens? They found that on the basal keratinocytes, oh, there is some antigens. I don't think this is our own antigen. This is some kind of foreign antigen. So they caught this LP antigen, and this Langerhans cell. What happens? Langerhans cell get this antigen. They take up this LP antigen and they go to the lymphocyte. Okay, so they go to the lymphocyte and they will present this LP antigen to lymphocyte. They will give this to lymphocyte. Okay, so that is why it is called antigen presenting cells. Now the lymphocyte will think that okay, this is some kind of foreign antigen. Let's go and kill it. Okay, let's go. Come on, guys. Let's go and kill the basal keratinocytes. There is these are foreign people. Okay, these are not our people. They are foreign people. Come on, guys. Let's go and kill it. Okay, so these lymphocytes. What are these lymphocytes? CD4 and your CD8. So your helper T cells and your cytotoxic T cells. CD8 is your cytotoxic. CD4 helper. They mainly your CD8. Most large in number is your CD8. Now what they do? They will come to your keratinocytes. Basal keratinocytes. They will come to basal keratinocytes. They will not come alone. They will bring a large army with them. Okay, the lymphocytes will not come alone. They will bring a large army with them. Come on, guys, let's go and attack the basal keratinocytes. They will attack this basal keratinocytes, and what they do is they will kill it. That is called a cytotoxic killing. Cytotoxic killing of your basal keratinocytes. What happens when the basal keratinocytes die? You will see that the killing of this basal keratinocytes is happening. The basal cell will be degenerated, or the basal cell is dying. So that area will become a empty area. The space will be there. Spaces will be there in the basal layers. Basal layers where the basal cells were there. there will be empty spaces. That spaces are called Max Joseph space. Okay, Max Joseph spaces. And in that spaces, you can see this dying keratinocytes. In the spaces, you can see the dying or degenerating keratinocytes. Is these degenerating keratinocytes will be dark pink in color. They are called civet bodies. Civet bodies. Okay, as the retar ridges were so smooth as this, but due to the dying keratinocyte, the basal keratinocytes are gone. So what happens? This retar ridges will become irregular here. Okay, the basal keratinocytes are all damaged and that area goes irregular. So the retar ridges will become sawtooth retar ridges. Okay, sawtooth retar ridges. So this is what happens in the lichen planus. There is no need to buy hard things. Understand things. Understand pathology, and there is no need to buy hard. Okay, you should know what is happening. So in lichen planus, all the problem started with the understanding, like misunderstanding. So in our life also, misunderstandings can make so much of problems, right? So misunderstanding, Langerhans cell misunderstood this LP antigen on the basal keratinocytes are foreign antigen, and this Langerhans cell, I think he's just like a neighborhood anti. Okay, he got this information and he spread it everywhere. Okay, so Langerhans cell is just like a neighborhood anti. She caught this news from this basal keratinocytes, ran to the lymphocyte, okay, and told that, oh, bhai, this is one CD4 and CD8. Come, there is news for you. He gives this LP antigen to them. CD4 and CD8 is just like they ran to that area, and they invade to that area, go to that area, they attack this basal keratinocytes. That's why in lichen planus, in the histology, you see a dense band of lymphocytic infiltrate in the in the basal regions, in the below your epithelium, in the juxta-epithelial region, juxta-epithelial band of lymphocytes. Why this? All the CD4 and CD8 came there. Okay, they will attack this basal keratinocytes, and what they do, they induce cytotoxic killing. Once they kill the basal keratinocytes, there is space left. Wherever there was basal keratinocyte, the space will be left. That space is called Max Joseph space. This Max Joseph space consists of the cells dying keratinocytes. They are degenerating keratinocytes. They will take more of pink in color and they are eosinophilic. They are called civet bodies. Okay, whenever there is a basal keratinocyte damage, that area will become irregular, just like sawtooth. Irregular like a sawtooth. Okay, simple. Now you know the reason of lichen planus. Now you know the histology of lichen planus. Now you can answer any question they are asking in lichen planus. Okay, that is it. That is it. It is done. So let's see this. This is a lichen planus, how it is clinically present. The interesting feature of lichen planus, the clinical presentation, is that they have lace-like white striae here. Okay, so they have this lace-like white striae. They call it Wickham striae. Wickham striae, and Wickham striae is very necessary to diagnose lichen planus. To diagnose lichen planus, there should be two things. One is bilateral presentation. It should not be one side, it should occur on both sides. The clinical diagnosis of lichen planus mandates that it should be present on both sides, bilateral presentation and Wickham striae. Two things should be there, bilateral presentation and Wickham striae. So if you are running your clinic, if you are running your own clinic, or you are working somewhere, if you are, or you are in your OPDs or in your college, anywhere it be, don't write lichen planus if it is on one side. Okay, the clinical consistency, clinical relationship of this lichen planus, you should relate it clinically, that whether this is present on both sides. Mostly it comes in the buccal mucosa. Females are most commonly affected. I told autoimmune disorders, so usually females will be affected, because autoimmune disorders, collateral damage things, females are the most interested people in that. Okay, so females will be having this lichen planus mainly in the menopausal age, due to stress, mainly this happens. Okay, lichen planus happens. We don't know the exact reason, what is the initiator for this, but usually seen in the menopausal woman and all. Okay, so one thing, bilateral presentation. Second is this lace like white strands, that is called Wickham striae. It should be seen. Come to the histology. The blue things you are seeing here is dense band of lymphocytic infiltrate. The blue band you are seeing, and it is just like a band just below the epithelium. It is called a juxta epithelial. Okay, juxta epithelial, juxta epithelial band of lymphocytes. Okay, so this is lichen planus. If you see the higher power, this is the higher power view. You can see that the basal keratinocytes are damaged, and this lymphocytic infiltrate is there. Okay, this is a IBQ image based question. You just have to identify this band of lymphocyte. It is not diffuse, it is band. See here, the connective tissue is completely clear. Just below the epithelium you have infiltrate, and below that it is very clear. Okay, that is the band like presentation. It is not diffuse. I'm saying it again, it is not diffuse throughout, it is just a band, right? So this is about your lichen planus. Okay, now along with this lichen planus, I want to tell you that if I do a direct immunofluorescence, okay, if I do a direct immunofluorescence uh, against this lichen planus, what I can see is that I can see what is deposited. What is deposited is that the fibrinogen component is deposited along this along this basal cell layer. Okay, along this, where it is deposited in the basal cell layer, basal cell region or basement membrane region, and how it is deposited in a linear shaggy pattern. That place is really shaggy because of this dying keratinocytes. Okay, because of this dying keratinocytes, what happens there is that I can see that in direct immunofluorescence, fibrinogen and C3 is mainly deposited in the basal cell region or basement membrane zone in a linear shaggy pattern. Okay, just remember that this is a DIF of your lichen planus. Okay, now I have a different concept. I have a very important concept to clear here. You know, you may have heard about a term called oral lichen planus. We have heard OLP. Now, have you heard about the oral lichenoid reaction? Oral lichenoid reaction. What is mean by oral lichenoid reaction and oral lichen planus? This is a very favorite MCQ question in your NEET, just based on a simple concept. Okay, just based on a simple concept. Oral lichen planus, now you know. What do you mean by oral lichenoid reaction? Oral lichenoid reaction will also clinically resemble your oral lichen planus. It will also have this similar appearance of your lichen planus. Okay, it will sometimes be bilateral or sometimes be unilateral. Oral lichen planus should be bilateral. Becomes striae is sometimes seen, also sometimes seen in your becomes striae is not always seen. Okay, not always seen in this lichenoid reaction, but it is always seen in the lichen planus. The difference is that oral lichenoid reaction will be always due to some underlying factor. The person may be having some kind of drugs, means some kind of medications, or he may be having a restoration. Okay, he may be having graft or graft versus host disease, or some kind of foreign implantation, graft versus host disease. Okay, he may be having some kind of antibiotics or NSAIDs, beta blockers, any drugs. The person will give you a history of having some kind of medications. So due to this medication, what happens is that the person may develop some white lesions in the oral cavity that will look like a lichen planus. Okay, that will look like lichen planus. Okay, so that's why we tell that the person should be the doctor should take a proper history before telling it is lichen planus or not. It may be a lichenoid reaction, you may not know. Okay, so this is for your practical application also. You should differentiate between lichen planus and lichenoid reaction. Okay, one thing, if it is present unilateral, it may be a lichenoid reaction, it may not be a lichen planus. And ask the patient whether you are having any drugs or what. Okay, and important factor is that which is dangerous, lichen planus or lichenoid reaction. which will transform to a malignancy. So you know that lichen planus is a pre-malignant lesion, or we call it now OPMD, oral potentially malignant disorder. Which is dangerous? Your lichenoid reaction. Okay, your lichenoid reaction is far more dangerous than your lichen planus. Okay, so according the malignant potential in lichenoid reaction is far more higher than your lichen planus. Okay, so that is the danger part in this. So that's why we say that history taking should be proper. You should differentiate between lichen planus and lichenoid reaction. Okay, so this is the concept I wanted you to clear. There's a term called lichenoid reaction. This is a very favorite area for MCQ, because the INICT need people, they want you to know the difference between lichen planus and lichenoid reaction. That is a must. Okay, so this is about your lichen planus. I hope you understood. See you in the next video with a new topic.